Right. I mean, obviously, if somebody will be able to record the whole.
Yes, yes, it will be recorded.
Yes, it's already recorded.
It's being recorded now, and it's on YouTube, Ravi.
Okay, that's good.
So we'll give you the YouTube link so that you can, and it will be on YouTube.
Okay, that'll be nice.
And you would know. Sorry, Ravi, I couldn't speak to you that day, but I'm sure you have figured out how to share the screen and all of that.
Yeah. Actually,
Yeah.
I got my daughter to log in on her computer from where she lives,
Quite
and I
easy.
had a test run.
Because we are doing the exams now. The pain exams are in this format, and we can get the candidate to even write on the clipboard, on the whiteboard, and we can see them writing. So it's very, very, it's very, very good.
Yeah.
But we have a few practice sessions before the exam, and we are having one. We had one last week, and we're having another one tomorrow. Between the examiners, just to make sure that it runs nicely on the day. But I was very, very skeptical at the beginning, thinking, how is this going to work? So it works just like in the college. The candidates are brought in, they are put into one room. The examiners, we are in our own room, we can chat. Then we go into the breakaway room. So the two examiners into one room, and then we have a little chat. And then the administrator can then bring the exam candidate into the room.
Oh, interesting.
In the same room?
Yeah, yes, they have mastered it. And so there are so many rooms, and the admin person does it. So all the candidates are in the waiting area first. They are put into a waiting area. The examiners are in our own room, and we chat. Then before the exam, we are put into the cubicles, as in rooms. So room, table A, table B. So table A, 2 examiners, table B, 2 examiners. And then we have a chat, and we just go through the paper. And then when the bell goes, they send the candidate, and suddenly the candidate appears on the screen in our room.
Fantastic.
Okay.
And then when we talk, if they want to draw, they can share the clipboard. So if they say draw the action potential or something, they can draw it on their pad, and we can see it.
Right.
Fantastic.
Okay.
Very good.
What about the written one?
Written one also is on this system online. And our pain exam, we did it last week, and it went very well. Unfortunately, the part 1 anesthetic exam was a disaster.
Was it? Oh,
Yes,
Wow.
because they were doing it in different days, and it's a very reputable company, and I did sort of warn the college that these are problems, and they assured us that there won't be any problems, and that it has been tried and tested. And so they did the written exam last Thursday, and half the candidates couldn't log on.
Oh God.
Some took an hour to log on, so they had to delay it for them. It was so stressful. And the reason for that was the company that was doing this. They are very reputable. They are the ones who run the licensing exams and all of these things. One of their clients was sending a large file that takes 2 days to download.
Oh my God.
Oh.
And during the exam, they decided to do that without knowing. And so it's completely upset.
Server was jammed.
Oh.
So we have lessons to learn, but so I don't know what they're going to do with the candidates who couldn't do it.
The primary FOC MCQ had those.
That's the one I'm talking about.
already.
Yeah.
Okay. Yeah. About that. Yeah.
There's always technical glitches.
Yeah, it's nothing like face-to-face, but obviously we canceled the first exam in March, so they were very keen on
Taking this one.
Going. Yeah, so we did it, and now the Viva is in 4 weeks' time, so we are hoping that there won't be a glitch, and that it'll go through. For pain exams, we don't have large numbers, so we can manage. We have only 22 candidates, so that should be all right.
Perfect. That's great. So we are in a new normal situation already.
I know.
What about in England? A friend of mine said that the cases are a little increased nowadays.
Yes.
On the last Sunday, it was 2,988. So that doubled.
2,000.
Yes,
So
sir.
it came down to
Almost
100,
3,000,
right?
almost 3K. Yeah,
These are just positive cases.
yeah. These are the positive cases, and
Only
amongst
2
them,
or 3
mostly
cases.
are asymptomatic, and there are less hospitalizations yet, but the case numbers are rising pretty sharply.
Mhm. What about masks and everything? Those are mandatory?
Yes, in shops and yes, buses and public transport and rest. Yeah.
But the place I'm staying in, I see from the windows they are not wearing the masks or maintaining any distances.
Is it?
Yeah.
On the roads, you don't need to wear them.
No,
Okay.
no.
In the
When you get into
confined
shops-
places.
When you get into
Yeah.
shops,
Shops,
and
confined
restaurants
places.
and places like that, you've got to wear them.
Yeah. No problem.
And all the shops, they mention on the door front, say you've got to wear a mask. And they have the right to actually,
Yeah.
send you
Restrict.
away. But obviously for business, it's not good for business.
In Philippines, my wife is there in Manila, so they not only the mandatory mask is not only mandatory, but they have to
Assalamualaikum,
wear the
sir.
face shield also.
Walaikum Assalam.
Assalamualaikum, sir.
Assalamualaikum, sir.
Assalamualaikum, কি খবর কাজী? How are you?
Hello,
Hello,
Alhamdulillah.
Dr. Iqbal.
Hello.
Sir, Victor এখানে.
Victor
How are you,
কোথায়?
Iqbal?
Where are you, Victor?
I'm here.
I'm sure you are there, but I'm just trying to look. There you are. Okay, how are you? All right?
Lovely. Yes, yes. You haven't been traveling, I suppose, recently because of all.
No. Nobody would take us. So how's the weather up there?
Weather?
Good?
Oh,
Weather?
it's not too bad. It's we were lucky during lockdown with the weather, but it's getting a bit cold now.
Oh, well, it ought to be. It's September, isn't it? I mean,
It's September. Yes, yes.
It has to be cooler than. Oh, yeah. Actually, it will be setting in October quite well, I think.
Yes, yes.
Okay.
So you're looking younger every time I see you.
Well, young at heart.
Very good.
Young at heart.
Very good.
I understand that's Dr. Nair. Dr. Nair.
Yes.
Hello, Dr. Nair. I'm the oldest guy in this whole webinar, see, and probably the oldest. And yes, it is. I'm the oldest one. Yeah.
And the most distinguished.
Yes, in a
Absolutely.
way, I've got some more gray hair than the rest of you.
I'm very similar to you.
Yeah, it looks that way though. Yeah. It looks that way. Yes. If I take a closer look, I think you are almost like me, but age-wise, you are definitely much younger.
Oh, that's a familiar sound.
Honking.
Yes.
Honking goes very strong around this part of the world.
Yes, yes, it's lovely.
Yeah. Which part of you are working in England, aren't you, Dr. Nair?
Me?
Yeah.
Yeah, Victor and I are colleagues.
Oh, I see. You are in London.
Yes.
You are in London then. I see.
Yes.
Okay.
Just outside London. I live in London, but we work, about, is it
About
20
35
miles?
miles. Yeah, about
Yeah.
35 miles.
Yeah.
That's not too bad.
Yes.
Yeah.
You have got underground.
No, we don't. We have only overground here.
Overground.
But they have, from Chelmsford, you have really fast trains to central London.
Oh, I
Yeah.
see.
About
That's
How long
not,
does it
half
take,
an hour
Victor?
to central London.
Should take 20 minutes, I think. Should,
Yes,
or maybe,
half,
maybe
an hour,
half,
half an hour.
maybe half an hour is the most.
Yes.
Kaji, how are you doing? All right?
Yes,
Hmm?
sir. I
Your
still have
mission,
2 more days.
mission accomplished.
I'm halfway done, sir. Didn't get a seat yet, but I'm doing the courses, and after my 2 days of prison break, then I'll be doing the course in the spot in the
Okay.
academy.
Okay. All best luck. All the luck for you. Mm.
Thank you, sir.
Mm. We are
Assalamualaikum, sir. Ajay sir is here.
Oh,
Nair is here.
just came from theater. Have a shower.
So, Shijan, when do you start?
Sir is away from the screen.
Miss moderator.
Sir, we'll be starting within 5 to 10 minutes. We'll
Okay.
wait till 8:15, I think, when the participants will arrive.
Okay.
Okay, sir. Just
Okay.
give us 10 or 5 minutes.
Okay.
So we already have almost 40 here, and the rest are live on YouTube, because
Okay,
this
that's
whole session is live on YouTube, and
very good.
people are watching from there as well.
Hmm.
Those are the people we can't count from here.
Yeah.
So 40 is good
we'll-
to start, isn't it?
Yeah.
Yeah, pretty good.
Yeah, not bad. Mm. We are very conservative on that. Even not bad is probably the term I would have used.
Kaji, any contact with Firdaus?
Yeah, so I have contacted with Firdaus Bhai, and Bhai invited me to be over there in his house.
For a dinner, I guess.
Yes.
Okay, you are in quarantine.
Yes, still, sir. Till
Sir,
9.
after finishing the quarantine, sir.
Yeah,
Oh, I see.
after that, obviously, after that.
You are doing all this
Yes, sir.
being in quarantine, is it?
Yes, sir, online.
Online, yeah. Not,
Online.
no. How long it will take? 14 days, 15 days, is it?
Yes,
Yes,
sir.
14 days. Sir. Your quarantine will be over
9th
on
of
9th, right?
September.
Yeah.
Yeah.
Okay. And she will be staying 7 more days, sir. So
Then
you can have dinner.
Then
Yes.
back to Pavilion.
Yes, you can get yourself to see some.
Sir,
something.
Lutful Ajit sir is trying to say something, but sir, you have to unmute yourself first.
It's okay now. Now
Yeah.
I can
Yeah.
unmute. It's
Yes.
okay. Thank
Yes.
So we are going silent again.
Yeah, we'll do that.
Okay.
you.
muted.
We'll start. Yes, by 5 minutes. No problem.
Yes. Within 3 to 4 minutes, sir. Yes. 8:10 or 8.
8:10 is okay.
We'll start at it.
Okay, sir. Okay.
Just I have a question. So I've got my main, the talk is sort of divided into 3 sections.
Mhm.
So at the end of every section, should we allow opportunity to ask questions, or should we leave the questions to the very end?
I think we should leave it to the very end.
Okay.
Then we can discuss it for a longer time.
Okay.
Yes, sir. So if you are not interrupted, then we can finish it in time, sir.
Okay. What talk have you got to go to, Victor? Oh, Victor's unmuted.
We have the exam practice.
Oh, okay.
Yeah, it starts in about 10-15 minutes, and then it goes on for about 3-4 hours.
Oh,
Because
Wow.
some of us are examiners, some of us have to be candidates, and we have to go through the whole exam just to make sure that it works. And so, yeah, it takes a lot of time.
and that's from your home, is it?
Yeah, I'm from home. Yeah, so all of us are from home. Yes, and even on the actual day, we will be in our own homes. The candidate will be in their own home.
Okay.
And that's also a safety thing, because if you're all in one place in the college and the internet fails, we are all gone.
That's true.
Right. Okay, Nimmi, you can start, I guess.
I think Nimmi can show her face and start.
Nimmi has vanished.
She couldn't take the excitement.
কই গেল নিম্মি?
Apu will be joining.
এই যে আপু আসছে।
Yes.
Okay,
Sir,
I think you can
shuru
start,
korbo, sir.
Nimmi.
Okay. Yes, we have participants around 51. And okay, we can start, sir. Mishuk, তুমি কি slide sharing দিয়ে দিছো? Mishuk?
Slide sharing data. Slide sharing.
Yes.
And everyone else is muted. So let's start.
Okay. So okay. So hello, assalamu alaikum, and good evening, everyone. Thanks for joining in time. And I am Dr. Zahida Parvin. Welcome you all in our anesthesia masterclass series. It's a nationwide e-learning program for the anesthesia community of Bangladesh in collaboration with the Department of Anesthesia and Pain Medicine of Evercare Hospital, Dhaka, Bangladesh. And I'm very delighted to welcome you all in our first international webinar organized by Evercare Hospital. And I'm extremely honored to introduce our international speaker, who has kindly agreed to have this session all the way from UK. And I don't think I can express all of his experiences and versatile knowledge of all fields of anesthesiology, especially in regional anesthesia, in this short period of time. But I must give a glimpse of his empowerment in anesthetic field in a very short time before we start our session. So Dr. Ravindran P. Nair is an experienced consultant anesthetist for over the last 22 years at Broomfield Hospital, Chelmsford, Essex, UK, and which has the world's renowned St. Andrew Center for burns and plastics. And it's also the largest plastic surgery center in the whole of Europe. And he's the lead physician for regional anesthesia in his hospital due to his expertise in regional anesthesia. And he's also used to involve with the acute pain management in his hospital. And not only that, he's the director of Pure Course. And I should the abbreviation of this PURE is the Practical Ultrasound Guided Regional Anesthesia Education, if I'm not wrong. And as well as he's the director of program of regional anesthesia, clinical fellowship program also. So, and lots of that, of course. And lastly, I would like to introduce our honorable panelist, Professor Dr. K. Iqbal sir and Professor S.M. Jahangir sir. So, and both of them are beyond description and are a true living legend of anesthesiology of Bangladesh. And they created, they stand for, and they established this subject in our country with lots of dedication, and for which we can make ourselves proud anesthesiologists of our motherland. So, and lastly, our third panelist is Professor Akhtar Jamal sir, who is continuously giving his love and affection for the development of this subject. And okay, I'm not taking much time. I'll not take much nurse from time, sorry. And okay, I would like to request Dr. Luthulazi sir, who is the Senior Consultant of Anesthesia and Pain Medicine of Evacare Hospital. And he's the chief organizer of this e-masterclass series. And to start this session, I would like to request him to say something about our program today, and then please start the session, sir. Thank you so much.
Okay. Thank you, Nimi. We are doing this program for quite some time now, and then we decided that we should go international, and also national speakers should be here. So I contacted Victor, and Victor was very kind enough, after hearing my desire or a talk on regional anesthesia, he introduced Dr. Nair to us. And when I saw his CV, I was extremely impressed with it, so that today we have a fantastic speaker who will be talking on importance of regional anesthesia and COVID. I'll not take much time. I'll request Dr. Nair to start his presentations. Thank you.
Thank you so much to Dr. Aziz and Dr. Nimi and Dr. Mendes for introducing me to you all. Really, it's a great pleasure and honor, and I'm in distinguished presence, as you have just mentioned, professors who have led the light for anesthesia in Bangladesh. That is, I did not expect this. That is really an absolute honor to be in the presence of such leading lights. Thanks so much for inviting me. So the talk today, what I'm going to do is, I hope I apologize to people who are, advanced practitioners of regional anesthesia, because I'm not presenting anything groundbreaking. It's all there, it's all available. The talk is really aimed at, people who are, looking at starting regional anesthesia, who are practicing it, and who can get some tips and ideas from my talk. So I'm not, and it's also not very, I've not covered the length and breadth of it. And you will realize that as the talk goes along. Excellent. So shall I share the screen now?
Sure, sir. You can do it from your end.
Okay.
Yeah, we can see it.
Excellent. So as you can see, the topic is the importance of regional anesthesia during COVID pandemic. In my book, regional anesthesia has always been very, very important, but it really takes on a huge different light in when COVID came along, because because of the issues related to COVID. Now, this slide is quickly, a picture of the front of our hospital. As Dr. Nimi was saying, it's quite a large hospital. We are close to 700 beds, and we are tertiary referral hospital for head and neck operations, for plastic surgery, and we have a huge colorectal, upper GI, and orthopedics department. So we are quite a large hospital, and we do really fantastic work. And our department as well is quite large. We are probably about 60, 65 consultant anesthetists, and then obviously lots of trainees and lots of middle grade doctors. We have about 25 or 28 operating theaters. So we are, and we, as a department, we are pretty good. We seek each other's help, and we are very, very cooperative in the way we work. So it's a good environment to work in. Excellent. So the main focus of the talk is, this is the problem that general anesthesia has, which is it's an aerosol generating procedure. So anything that we do with general anesthesia, intubation, extubation, tracheostomy, manual ventilation, suctioning, any of these things listed there you see, they're all aerosol generating procedures, which means you have a huge viral load coming onto the environment we all work in, and therefore making the environment susceptible for, the people working there very susceptible to infection. And the best way to do is to try and avoid this if you can. Obviously, surgery can't be avoided because that's why the patient is there in the first place. But anything that can diminish this AGP is really, I'm sure, welcome for everyone concerned. So obviously, the intention is to avoid aerosol generating procedures. And the best way from our side to do that is to perform really awake operations and use regional anesthesia, and it really lends itself to operations being performed awake. And in this talk, I'm not really going to include the neuraxial blocks, which is spinals and epidurals. It's mainly peripheral nerve blocks and other blocks. So talking about awake operations, from the top, we have head and neck, where lots of operations can be performed awake, like you have excision of cancerous lesions from the scalp, the face. I actually have even done an incision and drainage of an abscess in the nape of a patient's neck. This guy was about 160 kilos. He had difficult airway. He was an insulin-dependent diabetic, and the operation, he needed to go on his in a prone position to have his abscess drained. You can just imagine what a nightmare scenario that would have been for the anesthetist concerned. And all we had to do was a superficial cervical plexus block on both sides, and we could be anesthetized, I anesthetized the neck completely, and we sat him up on his side, and we did the incision and drainage with him awake, and we sent him back to the ward. So it's an absolute lifesaver. So to do head and neck operations, obviously you need to do the anatomy of the nerves that supply that area, and you have all these. I've listed most of the nerves: supraorbital, supratrochlear, auricular temporal, greater auricular, lesser and greater occipital, infraorbital, mental, and superficial cervical plexus. So depending on the area where your lesion is located, these blocks are all very, very simple to do. All of the knowledge is there available in the internet, textbooks. They're all landmark based blocks and very, very superficial. So really very easy to do. All you need to do is understand the anatomy, get the landmarks, have a lot of patience and a bit of time, get a surgeon who really understands the situation, and all the surgeries on the scalp, on the face, they all can be done with blocking these nerves. Unfortunately, it's too large a subject to be covering in this talk, so I've just thought I'll mention it. So, and I have done them, so I'm not just putting it down. I have performed awake operations using these blocks in my practice, so it's not something which is theoretical. It is actually, I have done it. So if I can do it, anyone can do it. So coming on to this, awake operations upper limb, we use upper limb regional anesthesia a lot. As Dr. Nimi pointed out, we are a large plastic surgery center, And we have a plastic surgery operating a trauma theater from Monday to Sunday, 8 a.m. to midnight. And we do all the hand operations, most of them trauma under regional anesthesia. So we have a huge mass of experience doing awake operations. So just to list a few, hand surgery, you've got, as elective, you have the Dupotrons, you have the digital joint replacements, trapeziectomy, you can have forearm, the wrist fusion, and then forearm surgery, you have, talk about open reduction, internal fixation of bones of, radius and ulna, cubital tunnel release. Now, just to, point out, cubital tunnel release, which is the ulnar nerve release in the elbow, you can do this under, axillary blocks, but they also need, because of the variation in the distribution of the nerves in that region, you have a mixture of medial cutaneous nerve of the arm and also the intercostal brachial nerve. You'll have to do a separate intercostal brachial nerve to make sure that that region is blocked. So just remember, if you're doing axillary block for this surgery, you'll have to top it up with an intercostal brachial block. Shoulder surgery, you can do arthroscopic decompression, cuff repair, and you can also do, open surgery to a very large extent with blocks. And so, it's a huge list, and you really don't need to send patients off to sleep to perform these operations. And, I have done all of these operations awake under regional anesthesia. So what I'll do is quickly go through 3 blocks, which is axillary, interscalene, supraclavicular, and axillary. Quick recap of the anatomy and pictures of how they look under ultrasound. So this is just showing the distribution of the nerves in the upper limb. You've got the axillary nerve there. That's the medial cutaneous nerve of the arm. That's a radial nerve there. You have the musculocutaneous nerve supplying this area, medial cutaneous nerve of the arm there. And you have the median nerve there and the ulnar nerve there. And obviously all of this is supplied by the brachial plexus. This is also a pictorial diagram showing the various areas where the brachial plexus can be blocked. As you know, brachial plexus comes from C5, 6, 7, 8, T1. They're all nerve roots here. So if you use the interscalene approach, you're blocking this area, which is the nerve roots and the trunks. And you further down in this region, you block the divisions of the brachial plexus. And when you come down to the infraclavicular area here, you block the roots. And then in the axillary area, you block the branches of the brachial plexus. I won't go into the details of the brachial plexus. It's all there, all the information is available. This is just a picture showing where you actually scan for these blocks that I'm going to talk about. So you've got the interscalene there, you've got your supraclavicular in this region, that's where you scan. And finally, you've got your axillary scan here in the armpit. So let's start with the interscalene plexus approach. The interscalene, you visualize the brachial plexus at the root or the trunk. It's better not to go very close to the roots because, the roots are very close to the dural cuff, and you can get the local anesthetic going into the epidural space and getting a huge spread of the local. And, if you're using 20, 30 mils of local anesthetic, you can have a huge spread into the epidural space and a real catastrophe in your hands. So you want to try and stay away from the roots and possibly be very close to the trunks rather. And if you are planning to go to the root, you've got to put really small volumes like 2 or 3 or 4 mils, not any more than that. The brachial plexus here lies in between the anterior and the middle scalene muscles. And they really, they are called, the way they appear on ultrasound is we call them the traffic lights. So you see 3 circles or 4 circles stacked one above the other. This is a pictorial diagram showing, how, they come out. So you've got your anterior scalene muscle there. You've got your middle scalene muscle there. These are the vertebrae with the nerves coming out of the intervertebral foramen. and then you have your clavicle there and the first rib there. So then, as you can see, the nerve roots and the trunks are stacked one above the other. This is another picture of the same thing, a bit more of 3D. So you've got your vertebrae and the intervertebral frame in there, anterior scalene, middle scalene, and the nerve roots and trunks coming out, and your first rib. As you can see here, the scalene muscles come out, are attached to the first rib, and the whole thing is the subclavian artery and the plexuses are squeezed between the two muscles, and that these are all the landmarks that we use to identify the structures. There's another, diagram cross section showing the what we are trying to see. So that's the sternocleidomastoid there. You have a carotid artery, internal jugular vein, anterior scalene muscle, and the middle scalene muscle there. And this is how you will see, the plexuses arranged one on top of the other. I don't know if, I'm sure senior colleagues would have used nerve stimulator to identify interscalene plexus. And one of the signposts for us to say that we were in the wrong place was when the needle came close to the phrenic nerve and you see the patient hiccuping. And if you saw that, you knew you were a bit anterior and you'd have to direct your needle posteriorly to get to the plexus. Obviously, this is something we really are trying to avoid. Unfortunately, when you do an interscalene block, local anesthetic sort of migrates towards the phrenic nerve and also moves upwards. And invariably, you get phrenic nerve palsy on that side. And it's obviously with lower volumes, you can try and avoid this, but there's no way anyone can guarantee that phrenic nerve will not be affected in your block. So every time you choose interscalene, you've got to make sure that the patient has enough respiratory reserve to cope with the hemidiaphragmatic paresis that he'll have with the block. This is another cadaveric picture, very nice. So that's your antiscalene, posterior scalene, and these are the nerve roots and trunks coming out in between the two scalene muscles. So this is the approach. This is a bit low down here, just above the clavicle, but this is where you can actually start scanning for the interscalene. Once you've seen the supraclavicular fossa, you can move up the neck and look for the anterior scalene and middle scalene muscles to then identify the plexus. So that's your middle scalene, that's your anterior scalene, and you have your interscalene plexus stacked one above the other. This is the picture you're really looking for. Again, that's another zone anatomy picture. You've got your anterior scalene there, middle scalene, that's your sternocleidomastoid on top, and you have your divisions stacked, the trunk stacked above one above the other. For shoulder operations, you really need the upper branches, C5, 6 really. But the thing with the shoulder, if you want to do them awake, you also got the suprascapular nerve does get missed out sometimes. So when I do awake shoulder operations, I also go down to the supraclavicular fossa, and just in front of the inferior belly of the omohyoid muscle, you have the suprascapular nerve, where I go and put some local anesthetic. I call it the belt and braces approach. So if the local anesthetic doesn't catch the suprascapular nerve in the interscalene groove, it'll also, you can also get it in the supraclavicular fossa. So you're trying to, hedge your bets by doing both these blocks. The other issue with the shoulder surgery is the superficial cervical plexus, which supplies the skin of the shoulder. That can be also, you can do a separate block, and it's all in the same region. So if you that's the sternocleidomastoid, and at the level of C6, if you go behind the posterior board of the sternocleidomastoid and put about 10 mils of local anesthetic, you can anesthetize the superficial cervical plexus. So with the superficial cervical plexus, the interscalene, and then a topping up with in the supraclavicular area for the suprascapular nerve, all these three combined, you really can get a very, very numb shoulder, and you can sit the patient up, and the surgeon very happily can do a shoulder operation with this anesthetic. So that's the brachial plexus, another zone anatomy. Like I said before, That's the sternocleidomastoid, anterior scalene, middle scalene, and the classic traffic lights sign you see 1, 2, and 3. And this is where I was talking about. In this region is your superficial cervical plexus. If you go put your needle here and put lots of local anesthetic, then you got your superficial cervical plexus block. Then next I come on to supraclavicular block. This is a very useful block. It's called the spinal of the arm because the nerves are all packed very tightly close together. And if you put your local anesthetic there, actually the block comes on very, very quickly. So the anatomy of supraclavicular area is this. So that's your first rib there. And then that's the anterior scalene, that's your middle scalene. And as you can see, lying on the first rib is your subclavian artery, and all these nerves, get packed together. The divisions of the brachial plexus get packed together, and they sit on top and behind the subclavian artery. So this is just a pictorial representation of a cross section there. So this here is your first rib, and that's your anterior scalene arising from the first rib. That's your middle scalene arising from the first rib. And you've got your sternocleidomastoid there. And this is the lower belly of omohyoid that I was talking to you about. And somewhere in this region, the suprascapular nerve comes down, and then obviously it heads back toward the scapula and the suprascapular notch to supply the back of the shoulder. And as I described earlier, sitting above and behind the subclavian artery is a brachial plexus. Actually, on your scan, so this is medial, that's lateral. So the Americans describe this as high and out. That is their baseball terminology. So it's high and it's out, or it's superficial and it's lateral to the subclavian artery. So as you can see, the divisions are all, there's a matrix around the plexuses. So you have to, there's a debate whether one should be depositing local anesthetic around, or should we be piercing this, a plexus sheath and going in and, putting a local anesthetic. Also, the other problem is the lower elements of the plexuses are in this area, very, very close to the rib in that angle, and using the billiards technology, it's called the corner pocket. So you've got to ensure that your needle comes in here and puts lots of local anesthetic there to get the lower elements of the brachial plexus. Otherwise, if you're doing a hand operation, you might miss out the ulnar nerve, and you might have to go in and top up later. So it's a good idea to first of all, think of that and make sure that you're not missing out that region. Also, there are, in this area, you've got the other vessels coming to the transverse cervical artery, the deep cervical artery. They run through the plexuses. So when you're scanning the supraclavicular area, please make sure you're getting the Doppler on and locating these blood vessels. And once you know where they are, you can avoid them with your needle and then anesthetize the rest of the area. I actually go in, pierce this plexus sheath, and I call it, I put lots of local anesthetic. So I have a sort of funny terminology for this block. I call it the carpet bombing. So it's basically going in and exploding all of the brachial plexus. And it's not, it's a nice block to do. It does anesthetize the arm very quickly, but for a regional anesthetist, it's not very pleasing because, it's a very blind sort of approach. You're just putting local anesthetic everywhere and hoping that it gets all the nerves that you're interested in. So it's not my favorite block. I do use it, sometimes when I can't get to the armpit because the patient can't abduct their arm, or various other reasons, but I must admit this is not my favorite block. So this is, as you can see, the approach to the supraclavicular. You can do it in plane, you can do it out of plane. And you can see here the zone anatomy. That's your plexus is there. That's your needle with the reverberation, and local is going around and lifting the plexuses. This is another picture. So that's your first rib there, subclavian artery, and this is medial, this is lateral. So you've got the high and out position of your plexus. As you can see, this appears as a bunch of grapes, and this white area there is the plexus sheath, and the omohyoid is somewhere here. So you can put your needle here to really, sorry about that. You can put your needle somewhere here to get the suprascapular nerve, and then put your needle, first of all, come down here to block the, lower elements, which form the ulnar nerve. And once you anesthetize that area, you can then put a lot of local anesthetic all around it and get a good block. The next block I'm talking about is axillary block. This is really one of my favorite blocks. It's a beginner level block. There are no dangerous structures. There's no pleura near it, and there's no phrenic nerve near it. And also it's a very satisfying block. In my book, I call it a smart bomb, because you really identify every nerve that you're interested in, put your local anesthetic very close to it, and then you're sure that all the regions are blocked that cover the nerves are blocked, and it leaves a really happy anesthetist. So talking about the anatomy of the axilla, axilla is is a pyramidal space tucked between the arm and your chest wall. So the apex is pointing towards the neck, and the boundaries of the apex are the first rib, the clavicle, the upper part of the scapula. Medially, the medial wall is formed by the ribs and the intercostal muscles. Posteriorly, you have your scapula there, and then you have the muscles, subscapularis, teres major, and triceps. Laterally, you have the intertubercular sulcus of the humerus. Anteriorly, you have the muscles, pec major, pec minor, and the base is formed by the skin, subcutaneous tissue, and the axillary fold. So this is another picture showing the same thing. You have the anterior bonder, pec major and pec minor. Medially, the serratus anterior muscle and the thoracic wall. Laterally, the intertubercular sulcus, and posteriorly, the scapularis, teres major, and lat dorsi muscles. So if you take a cross section in your armpit, this is how you'll see. There's your humerus, that's your biceps brachii and the coracobrachialis, and the triceps underneath, and tucked in between the muscle groups is your axillary sheath containing your branches of the axillary brachial plexus, your axillary artery, and your axillary vein. This is another picture, showing a pictorial thing. That's your axillary artery, axillary vein, and the nerves located all around it. So this is a cadaveric picture of the same. So there's your humerus, the biceps, and this is where you'd be placing your ultrasound probe to get the picture. And between your biceps and your coracobrachialis is your musculocutaneous nerve. They're very small, but very nicely seen under ultrasound. In the cadaver, obviously, they're not very nicely seen. Axillary artery there, axillary vein, and you have your median nerve and your ulnar nerve there. The radial nerve should be located somewhere around here. This is showing an anatomical correlation of the same thing. Your axillary artery, biceps, musculocutaneous nerve there, median nerve, ulnar nerve, and radial nerve. The radial nerve is quite a large nerve. It actually sits on, there's a white line. I'm not sure it's very obvious, but inferiorly, you see really a white line, long line, which is the conjoint tendon of the teres major and the triceps. And the relationship between the radial nerve and the conjoint tendon is very, very constant. So if you find the white line, you'll always, if you go up into the armpit, the radial nerve sits on top of the conjoint tendon. So if you go into the armpit and find the white line, you will invariably see a white blob. It may not be very defined at the time when you actually scan for it, but it'll be a big white mass sitting on top of the conjoint tendon, inferior to the axillary artery, and that is invariably the radial nerve. If you put your needle into that space and infiltrate, the local anesthetic will start to float the radial nerve, and it starts to become very, very obvious. Median nerve and ulnar nerves are very, very nicely seen all of the time. So that's another similar picture with the cadaveric anatomy there, and that's your axillary artery. That's very nicely seen. It looks like an eye of a fish. So that's your musculocutaneous nerve. This is the conjoint tendon I was talking about. Conjoint tendon formed by the triceps and the teres major. These are the axillary veins, and you have the two nerves here. You see there's a white circle around it, and then there are these small black circles within the white circle. That's the ulnar nerve, oops, sorry. And that is your median nerve. So you've got 4 nerves, median, ulnar, there's your radial sitting on top of the conjoint tendon there, and your musculocutaneous. You can also see sometimes, because there's the medial cutaneous nerve of the arm, which leaves the axillary sheath quite high up. So you won't see it within the axillary sheath, which is this triangular space. It is located somewhere here in the subcutaneous space. So if you look for it, it'll appear like a real small diamond, very nicely seen, and you can block that if you want, if there's surgery happening in that region. So this is how you let them lie on their back. That's their shoulder there, and that's the biceps. And this is, you use a linear probe to do the block, and this is an in-plane approach to the block. This is the person standing at the head end. You can also do this. You can either be at the head end somewhere there, or you can be in this area. Normally I sit in this area and I perform the block. I don't do it from the head end. This is a similar picture. That's your triceps, coracobrachialis, biceps, musculocutaneous, and the 2 other nerves here, and the radial nerve is in this region. Similar thing. So that's your radial nerve, ulnar nerve, median nerve, axillary artery, and that's the musculocutaneous nerve. So this is just showing that, although typically you expect the median nerve to be there, ulnar nerve to be there, and the radial nerve to be there, but everybody is different, and therefore you can't just expect the location to be there every single time you scan an armpit. And so this is what the distribution is. This is the description, most common type, but you can also see the median nerve sort of in that sector, ulnar nerve in this sector, radial nerve in like that, and musculocutaneous like that. So always the scanning has got to be dynamic. You've got to scan the whole of the sector here to find the median nerve, and you can scan up and down the arm, because if you just scan at one part of the arm, you might not see the nerve. If you slide the ultrasound up and down the arm, the nerves start to become clearer. So the scanning is always got to be dynamic, so that you can actually pick up the structures easily, and that makes your block more successful. This is a quick video. It won't take very long. I thought I'll show, for the people who are starting off, who may not understand what the in-plane and out-plane is. So it's a quick video. I'll go silent and you can see this.
It is coming up. Okay. So that's the armpit, and that's the cephalad end, and that's the caudal end. And as you can see, the transducer is vertical, not transverse. And the needle comes from the top end, from the cephalad end, and it's an in-plane technique. And so that's how the needle gets in to the patient. So there you go. That's a sharp scratch coming up. Okay.
Go up onto the screen.
So there's your needle. So you can go to the screen. So now you can see the needles coming from the top end of the screen. That's the needle, perfect. And you can see it advancing towards the median nerve, and now it's pushing the median nerve down, and you can see me injecting, and that's the infiltrate of the local anesthetic, and it's pushing the median nerve away from the needle. Get it closer, and that is, so I've got the median nerve there. You can move the needle, go closer, so come out. There's a nerve, and that's the artery above it, and median nerve in front of it. So that's it.
So that's the median nerve there, and that's the ulnar nerve there.
So if you
It's not a great picture. So this is another video, a quick one, just showing the outer plane.
The first one was in plane. Now this is the second approach. It's called the outer plane, and my needle goes in like this. So that's my needle going. That's the needle approach. Sharp scratch. That's it. So, yes, please. Yeah. So now you can see here the difference is you can't really see the needle. You just see the movement of the tissue plane, and there's the infiltrate going in. So it's just, that's the ulnar nerve there. There's a needle and there's an ulnar nerve above it. So I've done the median nerve, and now I'm doing the ulnar nerve, and you can see the needle. And there's a needle tip, and I'm heading towards the artery and getting close to the, trying to find the radial nerve. And when I inject that, you see the radial nerve becomes, so this here is the radial nerve. It's not that obvious, but hopefully when I make the injection, it becomes more obvious.
So that there,
That's fine.
the nerve.
Let me get a nice.
Okay. So that was a quick demonstration of, in plane and out of plane. Obviously, when you capture them on movie, it doesn't really come up very nicely. I was talking about the intercostobrachial nerve. You can really, ultrasound that area, and you can catch the ultrasound, intercostobrachial nerve with ultrasound, but that's not possible every time because it's a really tiny nerve. But I did find it in a few patients, and I thought it'll be useful to share that as well with you. So here's the intercostobrachial nerve. So that's the nerve there. So that's the the triceps or the lat dorsi muscle there. That's a subcutaneous plane, and that's my needle coming in, and that's your nerve, intercostobrachial nerve. Very, very beautifully seen. I move the pointer away. There it is. When it infiltrate close to it, you'll see it become very nice. Very beautifully seen.
Yeah.
So that's the intercostobrachial nerve.
Separated from the fascia.
Oh, good. Oh, yeah, that's very nice. Yeah. Beautiful. You can see the needle on top.
Yeah.
Okay, that should be enough.
And can we?
So, okay, that's that. Right. So that was the upper limb operations that can be done awake. Now we'll move on to the chest wall and the abdominal wall. The operations that can be done awake, the main structure in the chest is the breast. And I've done really about 60 awake mastectomies in patients. You can obviously do abscess drainage, and if removal of implants, lumpectomy, and any lesion that you've got going on in the chest, even in males, you can use the same. You can do awake operations in them. You can also do inguinal hernia, umbilical hernia, paraumbilical hernia, femoral hernia. For inguinal hernia, you can use ilioinguinal block. For umbilical and paraumbilical hernias, you can use rectus sheath blocks. And for mastectomy and you can use paravertebral block. I've actually done inguinal hernia with a paravertebral block in one of the patients who had, he had a really low cardiac output, less than 35%. And also he had ankylosing spondylitis. So really his spine was also all fused up. So there's no way I could give him a general anesthetic or a spinal anesthetic, low spinal. So I spoke to the surgeon, and we said we'll try out, doing the operation under paravertebral block, and I actually did paravertebral block for him. So the next talk is going to be mainly focused on thoracic paravertebral block. I won't be talking about the ilioinguinal or the other abdominal blocks, for in the interest of time. So the indications I'll talk about the indications, the anatomy, various techniques, and evidence-based I've actually left out, but there's a lot of evidence available for paravertebral blocks. So the indications are breast surgery, mastectomy, augmentation, mastopexy, lat dorsi flaps. You can't do them awake, but it's a very good analgesic for when you're doing latissimus dorsi flaps for mastectomy. And obviously a mastectomy and axillary clearance, you can use them. Any surgery involving the back or the chest, you can use it for nephrectomy, you can use it for open or closed cholecystectomy and open hernia repair, as I discussed earlier. So the paravertebral space is a pyramidal space, present deep to the transverse process. So that you see here is the transverse process, that's the spine, and that's the vertebra. So it is located in this region, and it is bound anteriorly by the pleura there, and medially you got the vertebral body and the intervertebral foramen, posteriorly by the transverse process, and laterally you have it goes into the intercostal space. Medially, it connects with the epidural space and also connects with the other side via the epidural space. This is another picture of the same. So you've got your pyramidal space going on here. That's the vertebra, that's a transverse process, that's the paraspinal muscles, intercostal muscles there. And you have this endothoracic fascia, which divides the paravertebral space into an anterior compartment and a posterior compartment. The anterior compartment has a sympathetic chain there, and the posterior compartment, you've got your intercostal nerve and the dorsal rami coming up here. So if you go into that space and put your local, it'll catch the intercostal nerves coming out of the, as soon as they come out of the intervertebral foramen. Because the nerves do not have a lot of covering here, the block onset is really very, very quick. This is another very nice picture of the anatomy of paravertebral space. That's a vertebral body, spinous process, that's your transverse process, that's your lung, and that's the fascia there, that's intercostal muscle, and that's your intercostal nerve, and that's a sympathetic chain, and that's a superior costal transverse ligament there. And so you come in, and that's your paraspinal muscles. So you come in from this side and enter that space. That's another beautiful depiction of the space. So that's your transverse process, and those are that's a superior transverse ligament, that one. So deep to that is this pyramidal space containing the intercostal nerves, and in front you have the pleura. So this can be done, when I started doing paravertebral blocks, I used the landmark-based technique. Ultrasound guide can be used. It is quite a advanced block to do, because depending on if you have a really slim patient, the paravertebral space is very, very close to the skin. If you have an obese patient, the space is quite deep, and as you know, with a linear probe, the depth, as soon as the structures become deep, the resolution drops and you start to lose the needle and the space, and the injection becomes very, very fraught. You can do them awake, you can do them asleep. If you're doing an awake operation, you're better off sitting them up. Left lateral or right lateral is available, it's possible, but it's not very convenient. Prone is a good position, but it's not very comfortable for the patient. And just imagine having an asleep patient and trying to put them prone. That itself is a complicated thing. So, best is to try and do either sitting if you're having an awake patient. If you have an asleep patient, then doing them in lateral position. So, thoracic paravertebral block, in my book is it is the ideal block, one would hope for. So if you wanted, if you had a wish list of how your regional anesthetic block should be, you would want a nice sensory block, you wouldn't want any motor block, and you wouldn't want any autonomic block, or at least any effects of the autonomic block that you see. So all these boxes are ticked by thoracic paravertebral block, because only the intercostal nerves are blocked. So the intercostal nerves supply the intercostal muscles, and the motor effect of the intercostal muscles is not that great. A patient can still breathe with his diaphragm very nicely and cough with his diaphragm and his abdominal muscles quite reasonably. So, the motor block is not that clinically relevant. And also the sympathetic chain, even if it does block, you don't see the hypotensive effect that you would see if you'd done an epidural or a spinal, for instance. I have blocked a patient who had lat dorsi, flaps for both their breasts. They had bilateral mastectomy and bilateral breast reconstruction with lat dorsi. And I performed 26 injections, 13 on each side from C7 to L1. Just imagine if you had an epidural block from C7 to L1, their blood pressure would be in their boots and you would need inotropic support for them. Fortunately, that patient, their blood pressure was sitting around 190 systolic. I gave them a general anesthetic for the procedure, and they woke up without requiring any opiates, and they were very, very awake at the end. So that's how beautiful and ideal thoracic paravertebral block is. And that's, let me stop there. I'm a fan of paravertebral blocks. So this is the slide showing the landmark-based technique. You really mark out the spinous processes that you're interested in. And from the middle of the spinous process, you mark out laterally about 2 centimeters. And that's where the transverse process is located. And then once you've located the transverse process, what you do is you go in with your needle, hit the transverse process. And once you hit the transverse process, you walk off it by 1 centimeter. So your needle has to end up 1 centimeter deep to the transverse process. Do not look for loss of resistance. Some people tell you should look for loss of resistance because the superior costotransverse ligament, which the needle pierces, is not as tough as ligamentum flavum. So you really cannot appreciate every time the loss of resistance. And if you do chase loss of resistance, your needle might end up in the lung and you'll give the poor patient a pneumothorax, which you really don't want to do. So the advice is find the transverse process and walk off it by just 1 centimeter and no more. And because the paravertebral space is very, very, superficial, very located just under the transverse process. You don't really need to go beyond 1 centimeter. So this is just a picture showing what exactly I described just now. This is a sagittal view of the paravertebral space. So you've got your transverse process there, you've got your neck of the rib, and that's your pleura in front. These are the paraspinal muscles, and that's your superior costotransverse ligament. And so your needle comes in from below upwards, from chordate direction, going into capillary direction, piercing the superior costotransverse ligament there, and you locate your local anesthetic in that area. So this is a video which I had done for one of my patients where I did an awake operation. Unfortunately, this was, I had taken this in a laptop, which is very, very old. So it was for some reason, I could not, store it with the newer laptops. So what I did was I took a picture of it while it was showing on my older laptop, and because I can then use it. So it may not be that clear, but please bear with me. So that's a patient sitting up.
The blue dot on your monitor, and this is going to be capillary, and the not blue dot is going to be chordate. And I'm going to place the probe. It's a linear probe, high frequency probe, and I'm going to place the probe with the scanning from lateral to medial. So you see the rib, and then you start scanning medially, and you start seeing you see the pleural inflection and the triangular space, which is the paravertebral space. I'll keep doing it, I think. So I can see the paravertebral space now. And I use, press again, click. And I use 21 gauge, 110 millimeter sonotap needle, and I use it in plane. Sharp scratch. And try to find the needle. That's the needle. Please wait for this. I won't go away. You okay? You see the pleura falling away. There's no air, there's no blood, and you see the pleura dropping away. And that is the end point of the infection.
So as I described there, I hope you could all see the needle coming in, entering the dark space. And when you make the injection, the pleura is falling away. And that means you are in the paravertebral space. The pleura drops because of the weight of the injection. And once you see that endpoint, the first time when you do it and you see it, it's an absolutely beautiful sight. And the block is definitely going to work. So that's how you use ultrasound guided paravertebral block. This is just another picture showing how the paravertebral space appears when you do a sagittal placement of the transducer. So that's your costotransverse junction, the transverse process. That's the pleura there. That's the costotransverse ligament there, and your needle will come in, and that dark space just above the pleura, inferior to the transverse process, is the paravertebral space. Also, what you need to appreciate is, the pleura is very, very close by, and that's why, we insist that you should not walk out the transverse process more than 1 centimeter, because the pleura is so close and the lung is in front there. So you really don't want to be looking for loss of resistance to find the paravertebral space. It is sitting just there. You can also use it for rib fractures. It's a fantastic block for rib fractures. You can also leave catheters in there and run continuous infusions. When you get old patients with several fractures, they fall down and they have really no muscle mass to cough very well. And on top of that, if they have a rib fracture, they very likely develop pneumonia and die of the rib fracture. If you want to avoid that, obviously opiates are not good for elderly patients. They become very sleepy, they can't cough, and you have a similar effect. So the best mode of analgesia is regional anesthesia, either using a paravertebral block, or there are other modern blocks that have come along and you can use them as well. So this is another video quickly showing you how an awake operation can be done. I hope it is quite obvious to you. The surgeon is operating on a breast, a female breast. So this lady had a prosthesis, and the prosthesis got infected, and the prosthesis need to come out. And so we did this patient awake, and this is a video of that patient having the surgery awake. So I thought I'll just show it to you, because a picture says more than 1,000 words. So I'll stop that and go on to there's another video. This is an interview that I had with that patient, the same patient you saw the previous video who was having the surgery. And she just explains the situation, why we did. So this is about 2 minutes.
Okay. Hi, are you right?
Yes, I'm fine, thank you.
So what did you think about the, the injection that you had yesterday while you were awake? how did you feel when it was being done?
I felt very comfortable and safe having them done. Yeah, it was pretty quick and I felt like at ease. Everyone kept me at ease and kept talking me through what was happening.
Fantastic. And did you find the injections that were being done, were they unbearable, too painful, not bad at all?
No, like the first one I think was a little bit painful, but after that you kind of get used to it and it's pain that you can cope with.
And what did you think about being awake when you were having your operation? How did you feel any pain while this was being done?
No, I didn't feel any pain. Obviously, I could feel the pressure of what they were doing, but I couldn't feel any pain.
You couldn't feel any pain, and you were quite okay with it?
Yeah, absolutely
and
fine.
Would you recommend somebody else having this?
I would definitely recommend people having done.
Do you want to just describe why we did what we did? So in your own words.
So I'm 12 weeks pregnant, so having the general anaesthetic, I was told about the risks that it could have to the baby. So obviously I wanted to make sure that I had the right thing that was being less risk to my baby. So when I was told about this, that seemed like the best option to go through.
What we did was a few injections in your bag just by the side of your spine, which are called paravertebral blocks. And then we did not give you any pain relief other than that, and you had your operation while you were awake.
Yeah.
And you were absolutely fine with that.
Yeah, absolutely
and
fine.
you're comfortable afterwards.
Yeah, I feel fine now.
Excellent. Well done.
Yeah,
Thanks so
you.
much.
It's okay.
So that just demonstrates that this, you can do breast ops as well awake, and it takes on a completely different, context when you've got this pandemic going on. So coming on to the lower limb, we can do lots of operations on the lower limb with the patient being awake. Obviously, spinals and epidurals are the easiest choice. But a lot of the times you've got patients, obviously, who are very unwell. They've got low cardiac output. Vascular patients are always, having a multitude of comorbidities. And also a lot of them are anticoagulated, and therefore they can't have neuraxial blocks. And so again, regional anesthesia comes into its own for these sort of situations. So you can do, obviously take out cancerous lesions, use it for split skin graft. I have done 2 patients, above knee amputation can be done, but they need a lot of blocks. So you need to block the femoral nerve, the obturator nerve, the lateral femorocutaneous nerve, and the sciatic nerve. So you've got to do separate injections, and therefore it's quite tedious, and it's not, you don't see often people doing above knee amputation, but below knee amputation is really, really amenable to doing under peripheral nerve blocks. All you need to do is block 2 nerves, the sciatic nerve in the popliteal fossa and the saphenous nerve in the thigh, and you've got a completely numb leg below the knee. And then obviously the same thing can be done with for ankle surgery and foot surgery. And in our hospital, we have done several of these operations, awake, and it's not an issue. So this is just recapping the anatomy, the supply of the various nerves. You've got the T12 supplying that, the lateral femorocutaneous nerve, the femoral nerve supplying this area, the obturator nerve here, the ilioinguinal coming down above, the thigh there, and that's the supply of your saphenous nerve, the common peroneal nerve supplying here. This area is supplied by the posterior femorocutaneous nerve. It's really, until I started doing ultrasound guided blocks, I did not realize that I thought, this area would be supplied by the sciatic nerve. Obviously, I didn't know my anatomy. But when I started learning is when I realized that this is supplied by another nerve, the posterior femoral cutaneous nerve, and it's really low, huge supply, and it even comes down below the knee onto the back of your calf. So sometimes you might find when you're doing your below knee amputation that the patient might feel, because you haven't blocked the posterior femoral cutaneous nerve, they might feel when the knife is applied to this region, and it might be worthwhile having some infiltration ready to block that region. So it's a really huge supply. And so you've got your common peroneal nerve and the saphenous nerve supply here. So these are the nerves, the lower extremity, the femoral, lateral femcutaneous, femoral obturated sciatic nerve, and the posterior femcutaneous nerve. I'm going to focus really on the lateral femcutaneous, the femoral, and the popliteal approach to the sciatic nerve. I'm not going to talk about the obturator and the posterior femcutaneous nerve. So as you know, the three nerves that we talked about, at least the two nerves, femoral and the lateral femcutaneous, come from the L2, 3, 4. They come out of the intervertebral foramen, run in the substance of the psoas major for some distance, and then the lateral femcutaneous comes out of the lateral border. The femoral travels further down and comes superficially to travel beneath the inguinal ligament and then enters the thigh and supplies the thigh. So this is another pictorial representation of the dermatomes, L1, 2, 3, 4, and the other areas. That's a quick. So let's talk about femoral nerve. Femoral nerve supplies the knee, so we use it a lot for our knee operations. It also supplies the anterior and the medial aspect of your thigh. Just after it comes out of the inguinal ligament, underneath the inguinal ligament, it lies in the thigh, lateral to the femoral artery. So you have this famous, mnemonic vein artery nerve. More importantly, when you're using ultrasound, the muscles also become, anatomy of muscles also come into the picture. So as you can see, the femoral nerve is actually lying on the iliacus, and you have the psoas underneath. So it lies on the iliopsoas muscle. So when you scan this region, it's not just important to locate the femoral artery, because you have other opacities which are just lateral to the femoral artery, and you may not be really sure until and unless you look for the iliopsoas muscle, and then you realize that the femoral nerve is actually sitting on top of the iliopsoas muscle. So that's a cross section in the groin. You see that's the inguinal ligament. That's the iliopsoas muscle that I was talking about. You have your femoral artery and your femoral vein, and you see the femoral nerve is sitting on top of the iliopsoas muscle. So in this region, if you're not looking for the muscle, you might find other opacities, the subcutaneous tissue and things like that. And it might be very misleading, and you might wrongly mistake them to be femoral nerve. The only femoral nerve structure you should be looking for is the one which is sitting on top of the ilio. So it's a real sentinel post. This muscle is what really points to the femoral nerve, not just the femoral artery. So this is another pictorial depiction of the same. That's the iliopsoas muscle there, femoral artery, femoral vein, and the nerve, as you can see, is sitting on top of the iliopsoas muscle. So this is showing correlation between the scan. That's lateral, that's medial, that's your femoral artery, femoral vein. And this structure here is your iliopsoas muscle. And this, oblong structure there is your femoral nerve. If you bring your needle in from this direction, enter that area, put your local in, you'll start to see the nerve become more obvious. This is another scan picture showing the same. That's your femoral artery, femoral vein, the subcutaneous tissue. That's your iliopsoas muscle there, and that's your femoral nerve. Lateral femcutaneous nerve is a very interesting nerve. As you could see previously, it supplies a huge area. And I'm sure, you've worked with plastic surgeons who do get a lot of skin from the lateral aspect of the thigh. And, it is a very painful area because you're leaving raw skin, afterwards. So if the analgesia, if you just block this nerve, you'll get fantastic analgesia. Even if you're sending the patient off to sleep, just putting this block in makes a huge difference to the patient's pain relief afterwards. Obviously, if you combine this with femoral nerve, you get the whole thigh is, or at least anterolaterally, it's blocked. So you've got a really large area of your skin available for, grafting. And you can even, if they're having some surgery there, you can use the same combination to, for anesthesia as well. And as I was saying, the lateral femcutaneous nerve comes out of the lateral border of the psoas major, dives underneath the inguinal ligament, and near the anterior superior iliac spine, it runs between these two muscles. That's the sartorius muscle there and the tensor fasciae lata muscle. And in between the two muscles, there is a hammock-shaped space available, and the nerve generally lies in that area. Now, this nerve is quite small, so you won't see it in all patients. As long as you see the sartorius muscle and the tensor fasciae lata muscle, and you see the hammock-shaped space, if you go in and infiltrate with 10 mils of local, invariably you will catch the saphenous nerve. And I have done this innumerable times, and I've done patients for split skin graft, and it works even if you haven't located the nerve. So that's what I was talking about. So that's your sartorius muscle there. That's your tensor fasciae lata muscle. That is your hammock-shaped space, and in that space is your, saphenous nerve. It's very small and very nicely seen there. That's another picture of this similar, showing the same thing. That's your tensor fasciae lata, sartorius, and there, and that's the space that we're talking about. I have a nice video coming up which really shows that very nicely. Bear with me. So that's your tensor fasciae lata there, and the sartorius is there.
That's lateral frontcutaneous there. So that's your sartorius, and that's your tensor fasciae lata, and that's a hammock-shaped space between the two muscles. And you can see that's a nerve. Lateral frontcutaneous nerve there, beautifully seen, just there. Wow, I've not seen this so nicely before. Nice. Oh, look at that. Floating beautifully in local. Isn't it? Very, very nice. Oh, look at that. Beautiful, absolutely beautiful. Okay, that's good.
So that's the lateral frontcutaneous nerve.
Oh, that's fine.
And the next nerve I'm going to talk about is saphenous nerve. Saphenous nerve, it's the largest branch of the femoral nerve. It arises from the posterior division of the femoral nerve, and then it runs from the lateral aspect of the thigh to the medial aspect and heads towards the medial part of the femur. And in the middle of the thigh, it runs in the adductor canal. The adductor canal is a fibrous tube running in the middle of the thigh. It stretches from the apex of the femoral triangle, and it ends where the adductor canal stops, which is the adductor hiatus, which is an opening in the adductor longus, adductor magnus muscle, where it lets the popliteal femoral artery to run posteriorly to form the popliteal artery. So it's a fibrotuberous canal, and it contains femoral artery, femoral vein, the saphenous nerve, the medial cutaneous medial cutaneous branch of the femoral nerve, and the boundary is formed by the sartorius muscle anteriorly, and laterally you have the vastus medialis muscle, and medially you have the adductor muscles. And when you scan the region, you see that's the sartorius muscle there, that's the femoral artery, and that's the vastus medialis laterally, and the adductor muscles medially. And the saphenous nerve lies lateral to the femoral artery in this region. So if you go in and put some local anesthetic lateral to the femoral artery, you will get the saphenous nerve. It is not very obvious because there's the vasoadductor membrane there. They all contribute to the hyperechoic region. So you can't tell the nerve from the various other things going on in that area, but it doesn't matter. As long as you go into the adductor canal and put 10 mils of local anesthetic around the femoral artery, you will get the saphenous nerve. So this is, just showing where you position the transducer. And that's another picture of the same femoral artery, sartorius, vastus medialis, and the nerve is somewhere there, and you go in, put your video needle, and put your local anesthetic in there. Same picture. The last section of our talk is going to be the popliteal approach to the sciatic nerve. As you know, the sciatic nerve is the largest nerve in our body. It arises from L45S123, comes out of the greater sciatic foramen and runs underneath the gluteus maximus muscle, and then it runs along the middle of the thigh towards the knee. The sciatic nerve supplies all the muscles of the back of the thigh, all the muscles of the leg and the foot, all the skin of the leg and the foot except the anteromedial side, which is supplied by the saphenous nerve. So it's a really large nerve with a huge supply. So I'm just going to focus on the popliteal approach. And as you can see, this is a cadaveric dissection. You have the biceps femoris laterally, semimembranosus, semitendinosus medially. And that's the common peroneal nerve there. And that's the tibial nerve there. So somewhere, you know, along the popliteal crease, about 8 to 10 centimeters above the crease, the sciatic nerve splits into the tibial component and the common peroneal component. Actually, what I just said is not true. You know, we perceive it to be so, but right at the inception, the sciatic nerve originates as these two nerves. They simply run along together in one sheet called the parasacral plexus, or recently they're giving it various names, but the analogy is similar to the axillary sheath in the axillary plexus. Just like an axillary sheath covers the branches of the axillary nerves, the parasacral plexus covers the two nerves, which are two nerves at the very start, and when they come around the popliteal region, they start to separate and move apart and become two nerves. There are really two nerves all along. So when you look at it from the front, they are located deep to the popliteal vessels, artery and vein. But when you look at it from behind, the nerves are superficial to the vessels. So this is another picture showing the same. You've got the muscles on either side and the common peroneal nerve laterally and the tibial nerve medially. This is a cross section with the femur in the middle, and you've got all the femoral blood vessels, the saphenous there, and that's the biceps and the popliteal fossa with the two muscles on either side. So this patient is lying on their front, that is prone, and this is just marking out the biceps femoris, semitendinosus, semimembranosus, popliteal crease here, and somewhere in this region, they would have started to split into the two nerves. So this is a very nice, so this is what you would see. So this patient here is actually lying on their side. So that is how I also perform these blocks. I get them to lie on their side because it's more comfortable for the patient. Getting them to lie on their front, that's on their stomach, is really, really difficult for them for a prolonged period of time. Especially the patients who come to us for operations are elderly, they are obese, so they are not very agile, and you're causing them discomfort, or they might have a fracture in their leg, and getting them to turn is also very, very difficult. So lateral position is really good for us and for the patient. And as you can see, very nice picture here. In this spot, both the nerves are located together. They haven't yet split up. But you can see them sort of separate entities within that one common sheath. And as you scan towards the popliteal crease, they start to appear like a dumbbell or a kidney. So they start to sort of separate out into two nerves. So that's your tibial nerve, and that's your common peroneal nerve. And there's that sheath. So I'm not sure who, but they actually did a study to see if this was a sheath enclosing the two nerves, and whether there were any neural structures in this space. And what they really found was that you could actually put your needle into that space and put your local anesthetic there, and you won't actually be performing an intraneural injection. It'd be the same as doing an axillary block within the axillary sheath. That would be the effect. So you have better spread of local anesthetic all around, and because you place the local anesthetic closer to the nerve, the onset will be quicker. However, like I said earlier on at the start of this talk, this is the largest nerve in the body. And therefore, if you're performing an awake operation, you've got to really give it a lot of time to work. And I would say a reasonable time would be 1 hour after you put the local anesthetic in. That is how long the block takes to, really set and for the patient to be completely anesthetized for you to do an awake operation. Obviously, if you're using it as a part of your general anesthetic, it doesn't matter. But if you're doing an awake operations, you really have got to wait for at least an hour, if not longer, for the block to make a nice, dense block. This is another beautiful picture I got from the internet showing the two nerves separately within that sheath, and the local anesthetic is surrounding it beautifully. I have, got these pictures. Unfortunately, when you're in the heat of the moment, you can't capture it, forever. And afterthought, you say, oh, I should have got a picture, but unfortunately, I haven't managed to do that. But this shows the two nerves very, very nicely. You have your tibial nerve medially and your common peroneal nerve laterally. So this is just a video of one of the elderly ladies that I looked after. She was probably 88-year-old, had lots of problems, and came with this a sort of wound in her leg, and we were going to clean it, debride it, and bring her back for a later date for skin grafting. So this is what I did, these blocks that I just described. So this region will be blocked by a sciatic nerve, and sorry, this is medial, so that will be a saphenous nerve, and laterally will be your common peroneal and tibial nerves. So this is that. And the next slide, actually, I've got the video of them actually doing the surgery for the patient.
Actually, without the tourniquet is fine, because we'll see if it is any bleeder. We can. Yeah. Actually, for me, sorry, this is your job, you know better. But for me, if we can have this kind of block, available in others, that would be a great thing to do with these kind of hematoma. But usually elderly or warfarin, this and that. That would be great actually. Actually, we don't.
So that's that. So you can really, with this combination of popliteal block and the saphenous nerve for the anteromedial aspect of the leg, you can do below knee amputation. You can fix the bimalleolar fracture of ankle. You can do any forefoot operation. So it's an absolutely brilliant and versatile block to perform for all our patients. And that brings us to the end of my talk. Thanks very much for listening to me very, very patiently. And I'm happy to answer any questions you have.
Okay, thank you so much, sir, for your wonderful discussion on the most demanding topic on this pandemic situation. And you almost covered up all the regional blocks, which definitely will help all the postgrad students as well as the practicing anesthesiologists. Now, before we move on to our next question and answer session, I would like to request one of our panelists, Professor Kemi Balsar, to comment on today's deliberations.
There's not much to comment because I'm not an expert in this. Actually, I was wondering what I'm doing here. So anyway. Anyway, I'm an old-fashioned guy, usually a general anesthesia person. But in our days, in our training days, we did several brachial plexus block, and we didn't have the luxury of having sonar guidance or anything else. So we used our old methods of surface marking and all that. But we got away with it mostly, but we are not doing many regional blocks in those days. And I believe that things have changed. And for me, when I was still practicing, you cannot teach an old dog new tricks, and I didn't learn any. But nevertheless, encouraged others to go ahead and do as much as they possibly could. The presentation itself will be a gem to all the practicing anesthetists, because the new trend is to have more local blocks. And at one stage, I sort of predicted on sort of not a very qualified prediction, but I felt that probably general anesthesia, it is the beginning of the end of general anesthesia, because more and more people will be doing regional blocks, and they will be doing it very successfully. Dr. Nair has shown us that we can really do that, and that will be extremely helpful in these bad days of COVID-19, where he has started the first slide that has caught my eye, that what he call is this aerosolization, or the aerosol generation. That is a big problem with general anesthesia, and the usual ritual that we have associated with general anesthesia is the aerosol generation, and that we try our best to avoid, which is cumbersome in its own right. However, we here are also doing a lot of local or the regional blocks, and what Dr. Nair has shown us that we could do more successfully, more accurately, should there be the availability of the right kind of equipments all over. You know that very few hospitals have the fortune to have those equipments, but most of the hospitals that we probably have joined us here, most of the people who are working in those hospitals do not have these facilities. So that has got to be developed. Probably this will be an eye-opener. They will insist having them, and probably will be nearing somewhere, some standard, sometime to come. Thank you very much, Dr. Nair. And others who are doing more regional blocks will probably, who have joined us, they can give better opinions and better comments. But nevertheless, from me, you have done a great job. Thank you very much indeed.
Thank you very much.
Thank you so much, sir. And now I would like to request Dr. Azharul Islam, sir. He is the senior consultant and coordinator of the Department of Anesthesiology and Pain Medicine of Evercare Hospital, Dhaka. So, sir, if you could say a few words.
Thank you, Dr. Ravi Nair. It was a wonderful presentation. Some of the hospitals in Bangladesh, especially in Dhaka, are doing, if not all, most of the blocks you have shown. But nevertheless, we are trying to popularize those blocks. Even in our Evercare Center, we are trying to, before COVID, of course, some kind of hands-on attachment for a week, so that the registrars from other hospitals can have an exposure on the kind of blocks that we are practicing, or we could demonstrate to them. So that way we were trying to popularize regional blocks in our country. But as Sir was telling, that instrumental limitations are there in governmental, also in private hospitals. But nevertheless, it is taking shape. And I believe with COVID, the importance of regional anesthesia to avoid AGP is highly felt, and we will, the administration especially will take care of this and provide us some more machines to the government hospitals, so that at least teaching hospitals could disseminate this technology for the better benefit of the sick people. And thank you everybody for patience hearing, and it was really wonderful presentation. Thank you very much.
Thank you, sir. So I think it's already late and we can move on to our question and answer session. If you are okay with it, Ravi sir?
Nimmi, just a minute. Is Shoikat, are you in? Can you unmute Dr. Shoikat Sengupta? He's a friend of mine from Kolkata.
Shoikat is here.
Dr. Mishu, would you please unmute everyone and so that they can discuss?
Okay.
Okay.
Shoikat sir is
Yeah, this is Shoikat. Thank you.
Hi.
Thank you, Nipul. Yeah.
Would you
good.
please, sir, on your video so that we can all introduce with you, sir?
Just give me some time to then. Otherwise, I'll just talk on this. Thank you, Lutful, for sending me the link, and thank you for asking me to just butt in. And it was a wonderful presentation from Dr. Nair, taking us through the entire gamut of regional procedures that can be done for various kind of interventions, surgical interventions. And I think this it can serve as an excellent template for people to take it forward. I could understand from what some people were asking, as well as from the comments of very senior people over there, that there is a challenge for the lack of infrastructure. But I think, as Dr. Nair said, that it is not always that you need an ultrasound. There is always the possibility of doing safe regional procedures via the landmark guided technique as well. And this is something that we kind of say that don't get inhibited by the fact that you don't have an ultrasound machine. Be safe. And if you actually apply the techniques of an appropriate landmark guided approach to nerve blocks, I think you'll be doing fairly well. Of course, there are certain blocks which is extremely difficult, or rather impossible without an ultrasound. So that is there, but that should not be an hindrance to perform regional anesthesia even without an ultrasound machine. That is what I would say, and I would think that could be a take-home message from Dr. Nair's talk, is that you just don't always need an ultrasound. Ultrasound, if it is there, is very nice. Otherwise, get yourself versed with the landmark guided technique as well. That would what I would try to emphasize. Thank you very much for asking me to talk.
Thank you, Shoikat. Can we go on to question and answer now? Thank you, Shoikat.
Okay, sir. Ravi sir, if you permit, then we can take some questions.
Absolutely, yeah.
Okay, thank you, sir. So first question I would like to ask from, in an adult 60-kilo patient, case of prolonged operation of shoulder under interscaling, 20 ml with bupivacaine 0.5% and superficial cervical plexus, 10 ml bupivacaine 0.5%. What is your recommendations for establishing regional block before operation or at the end of the operation?
Obviously, I believe in doing all blocks at the start, because one is, our talk is about awake operations. Obviously, then, you can't perform it after the operation. So yes, if you're doing an awake operation, it's got to be at the start. But if you're combining it with a general anesthetic, then you're actually better off performing the block before surgery, because the idea is for you to have a patient who is comfortable at the end of the operation when they wake up. Also, to minimize the use of narcotics intra-op and have a light plane of anesthetic. A lot of research within the recent past has shown light on ill effects of narcotics. The biggest, live study, biggest sort of living example is the USA, where, at the height, they lost about 70,000, 80,000 patients a year to narcotic abuse. So, and these are all prescription opioids, not from illegally, not from the illegal market. So narcotic, the opioids are not really great drugs. They are a necessary evil, but if you can avoid it and minimize the use post-operatively, that much better. And also depth of anesthesia has a bearing on how the patients wake up. And, the post-operative nausea and vomiting is such a big evil in our lives for patients. So if one can really do away with it, you'll become a billionaire overnight. Unfortunately, we can't, but you can try and minimize it. So if you perform blocks before the start of surgery, you can keep a really light plane of anesthetic, and that contributes towards decreasing nausea and vomiting. Also, you're reducing the use of opioids, and again, that is also contributing to reduce nausea and vomiting. Plus, the patient does not have pain when they wake up and they are nicely orientated. Those factors also contribute to, decreased nausea and vomiting. So there's a whole load of things benefit in doing blocks before surgery starts. If you want to extend the block, for longer duration because of the intensity of surgery, you can always put a catheter in and prolong the block for post-op period. So in my book, there's no way that I'll do a block at the end of the operation unless, we did not plan it at the start and we thought of it after the surgery has started.
Okay, sir. I missed a line of the similar question. That what is your recommendation for top-up doses in terms of volume and required time interval? In the case if patient is having a prolonged shoulder surgery with bupivacaine 0.5%, 20 mL in interscalene and 10 mL in cervical plexus.
So
what's
your
recommendation?
If you're leaving a catheter in, then you can run an infusion. Here we tend to use ropivacaine. I also don't use bupivacaine in my practice. I only use I use a combination of ropivacaine and lignocaine, and we run ropivacaine infusions, not 0.2%, and you tend to run it at 6 mL an hour or so, and adjust it accordingly depending on the response of the patient. But there is a problem with continuous infusions. It's not a panacea for all ills. Because the catheter is located and it's not very mobile, and therefore after a while the patient does start to get some pain, and therefore a combination of boluses and infusion is a better mode of delivery rather than just continuous infusion. The boluses, if your machine allows the patient to get some boluses, you have a set lockout interval and the patient can bolus themselves. But what we tend to do is we probably bolus them about 10 mL of say 0.125% or 0.25% ropivacaine on top of the infusions every so often, just to establish the block again and keep it going. Because lots of studies have shown if you just run an continuous infusion regime, patient analgesia is not that fantastic.
Okay, sir. Another question is, what should be the time interval for plexus block, the brachial plexus block, if required for the repetition?
Sorry, I didn't get that.
So if brachial plexus block is required for repetition, so what should be the time interval?
You mean the bolus?
No, sir. If a repetition of the block is required. Same brachial plexus block. Yes, single shot block. Again.
Yeah, you can, obviously, if the patient is coming back within the, you can always test if they're coming back within few hours, because the block duration, if you're using a long-acting anesthetic, it can last up to 9-12 hours if you're using bupivacaine, sometimes longer. So if the block's still working, there isn't a need to repeat it. If the block has worn out, there is no problem with doing another block. Because where we are, we get patients who come back for second look, third look, and fourth look. So very often the patients are done repeatedly under blocks and we have not had any complications.
Okay, so there is no exact time limitation, so where we can perform the another block.
No.
So there is no time limitation. Okay.
And sometimes, as I'm sure a lot of my senior colleagues will admit to that, in the olden days when we didn't have ultrasound guided blocks, we'd do transarterial brachial plexus, and you'd wait for an hour, and sometimes you see some of this is either median or radial, or one of them is missing. It's not working properly, so you bring them back and you try and do it again within the hour or so, and wait for another half an hour, and sometimes the block works, and then you get on with the awake operation. So yes, there isn't a set time when you can repeat the block.
Okay, sir. So move on to next question. For thoracic paravertebral block, what amount of local anesthetic per space used?
Right. So paravertebral blocks, if you're doing an awake operation, and I'm talking about breast operations, so the breast supply is T1 to T6. When I used to do them as a blind block, I used to block every single space. So to ensure, because you're waiting for about half an hour, and then you don't want to lose time. So really I was betting, hedging my bets and trying to catch all the nerves. And I would put in about 3 to 4 mils of local in every space. This young girl that you saw that I did, that was done recently. So I did 3 space injections for her. I blocked every other space, and I put in about 10 mils of local in every space. So, it was allowing for spread up and down one space at least. And, that was trying to cover my bet. If it was for analgesia, then if I was using ultrasound guided blocks for analgesia, I would probably do 2 injections for one breast. So 10 mils, 15 mils in each space.
In each space, okay. So I think similar to that question, like please let us know the concentration and the total volume used for the bilateral paravertebral block from C7 to L1.
Yes, so that was, that's the only patient I have done. I've not done that again. I used, we are limited by the mass of local anesthetic we can use. So I was putting, I think I used 0.25% ropivacaine, and I just used 2 or 3 mils in every space. So because that's 26 injections. So I did, it was quite an effort, but it is one of the best blocks I have ever done. That lady woke up, it was a 9-hour operation. I used a Tiva anesthetic for her, propofol and remifentanil. She didn't need a lot of anesthetic. All she got analgesia-wise was paracetamol and diclofenac. She did not receive any opioids, no fentanyl, no morphine at the end. And as soon as I stopped the Tiva, she just woke up and she was, absolutely pain-free.
What was the procedure?
A bilateral mastectomy and latissimus dorsi reconstruction of the breast.
Oh, okay. That's why C7 to L1.
Yeah, it was a 9-hour operation.
Oh, okay. Excellent, sir. So now next question is it will be very illogical to give paravertebral block without the help of ultrasonogram, as
no.
Peripheral hospitals have no access with sonogram.
As I said, when I started doing paravertebral blocks, even though I did ultrasound guided other peripheral nerve blocks, I wasn't confident enough to do paravertebral blocks with ultrasound, because those days the ultrasound machine that I had wasn't of great quality. So, the resolution wasn't great. So ultrasound guided paravertebral block is quite a difficult technique to master. So I was using landmark based technique, even though I knew how to perform ultrasound guided blocks. But the thing to be wary is you have to be very, very careful take your time to mark out the spinous processes, the transverse process. Be very careful when you enter the skin and find the transverse process with your needle. And the most important thing is to not travel beyond 1 centimeter after transverse process. That is very, very paramount to avoid, somebody's coming to you for a cosmetic procedure. You don't want to give them a pneumothorax. So that's, you've got to have that on your mind always. And there's no reason why you can't do a paravertebral block with landmark guided technique.
Among the discussed blocks, in which block local anesthetic toxicity most commonly have you seen?
Thank God I haven't had local anesthetic toxicity in all the years that I have practiced. However, I have seen it happening, with my, 1 or 2 colleagues. So this was one young man who was doing in a neighboring theater. He was doing a transarterial technique of, this is in the early days while I was in that hospital. And the patient did start to fit because I think it was an accidental intravascular injection. So, if you keep your maximal dosage within the recommended limits and you're carefully aspirating every time, obviously, accidental intravascular injection can happen in anyone's hand because sometimes you aspirate, you won't see anything coming back, and you might make the injection because the lumen of the vessel might occlude the needle lumen, who knows. But, if you take real precautions, you can reduce the incidence quite considerably. And now with ultrasound guided block, you're placing the local very, very close to the nerve. You can see the blood vessels. So you can try and avoid, causing all these, getting into those sort of trouble situations.
Yes, sir. Okay, then do you add any adjuvants with the local anesthetic for any block?
No, I'm not a believer in adjuvants. There are so many, they talk about clonidine, dexamethasone, dexmedetomidine, all these sort of things. I don't believe, doing the regional anesthesia itself is, a stressful situation. Even though I've been doing it for so many years, when I'm doing an awake paravertebral block, I am quite stressed because I want to get the block done and have an awake patient for the surgery and hoping that the block works. I don't want to add another stress to this already stressful situation. So, and you've got continuous catheters. So if you want to prolong the block, put a catheter in. Putting catheters, it doesn't take anyone, you've got to obviously be a bit more careful about asepsis and things like that. But it's not, if you can do a block, you can also put a catheter in. It's not a big deal. So if you want to prolong the block, you can always leave a catheter in. Adjuvants just complicate the situation, in my opinion.
Yeah, and what is your opinion on choosing PEC 1 and PEC 2 for breast surgery?
In my book, the gold standard for analgesia would be paravertebral block. These surrogate blocks that we have, that have come on to the scene, like PEX 1, PEX 2, serratus anterior plane block, erector spinae block, they are all what are called as opioid sparing blocks. So you will need opioids. The amount of opioids that you will need are quite variable depending on the patient. I don't think you can get away without giving opioids to these patients. Whereas if you did a paravertebral block for, say, mastectomy and reconstruction, and you had a sleep patient, at the end, you wouldn't need to give them any opioids, and the analgesia is absolutely stunning. Whereas with these surrogate blocks, you can't do an awake operation, or at least I haven't done one. There might be others in the audience who have done it and maybe vouch for it, I don't know. but the nerve supply just doesn't lend for an awake operation, and the analgesia is not complete like you would with paravertebral blocks. So you have to use adjuvant analgesia like paracetamol, diclofenac, or non-steroidals like paracoxib, and use some form of opioids. Obviously, it is very variable how much opioid you give them, but definitely you will need opioids for these patients. They are, one thing to say is that these are easier blocks to perform. So the scope will be very wide. And so also the time consumed is lesser. And also the patient's there is an analgesic effect. So I'm not saying that they are very, very useful, but if you're talking about what is ideal, then the gold standard would be paravertebral block.
Sir, I would like to ask a question. Like, do you use any remifentanil infusion or like dexmed infusion along with any kind of blocks, peripheral nerve blocks, especially in orthopedic procedures or things like that?
When so it's quite variable. When I'm doing paravertebral blocks, if this patient is going to, I'm going to do them awake, but if I'm going to send them off to sleep afterwards, then I would run a Remi infusion, very small dose. And when I have young patients coming for ACL repair, for instance, and they are very, very nervous, and I will be sending them off to sleep afterwards, but I'll have TIVA ready. So I'll start the Remi infusion before I do the injection. And once they are nicely relaxed, I will perform they will not be asleep, but I can use it for, analgesia alongside doing the awake blocks. But most of the time I do my blocks, also for axillary blocks and upper limb blocks, if the patient is very anxious, I do give them, midazolam, couple of milligrams, and that takes care of their anxiety.
Okay, thank you, sir. So another question, do you use ultrasonography scan for the mentioned head neck block?
Yes, superficial cervical plexus block. You can find the sternocleidomastoid, and then you can find the posterior border, and you can exactly locate the needle in that tissue plane. So it's very useful for that. If you're doing an auriculotemporal nerve block, you can find the superficial temporal artery with the ultrasound, and you can go behind it. And it is very useful for greater occipital nerve block. You can find the occipital artery behind, and then place the needle medially to get the greater occipital nerve. So yeah, in these three situations I would use ultrasound. All the other blocks are very superficial and landmark based, so you don't need to use an ultrasound.
So what is your preferred block for awake shoulder surgery?
Awake shoulder surgery is, my recipe is using a combination of superficial cervical plexus, interscalene, and the supraclavicular, wherein I go and find the inferior belly of the omohyoid and put some local anesthetic to catch the suprascapular nerve in that region. And that's the combination I do. And you wait for, in total, I would have used about 40 mils of local, 15 mils here. So within the 40 mils, I'm able to distribute the local anesthetic, and the patient has an awake operation. Only sometimes, when the surgeon goes below the area of because the superficial cervical plexus has a very wide supply. So it supplies the whole of the neck like that and the cape area, so the shoulder. But sometimes the entry point is below that and the trocar goes in underneath. So you might have to infiltrate the skin. The surgeon can do that. But a lot of the times, you're able to cover it even, without that. So this combination seems to work very well for me. I use in my mix 1% lignocaine. 1% lignocaine gives you a very intense block and a very quick onset block. So I use a combination of, say, I'll take 20 mils of 2% lignocaine with adrenaline and 20 mils of 1/4% marcaine with adrenaline, and you mix it together 50-50. You get 0.125% marcaine and 1% lignocaine with 1 in 400,000 adrenaline. And that combination really works very well because you get a really intense block and a quick onset. And obviously the bupivacaine will make it longer lasting. So that mix I use quite a bit in my practice.
So you don't use adrenaline or any other adrenaline?
Only
purely the local anesthetics?
No, the adrenaline, the lignocaine.
With adrenaline?
With adrenaline, yeah. Yeah, because you want to minimize the absorption and, because you're using 2 local anesthetics.
And last question I have, what is your favorite local anesthetic agent?
I use ropivacaine a lot in my practice because, even when I'm doing general anesthesia, I do a lot of blocks. For instance, if I was doing a hip operation, I would do a fascia iliaca block, I would do a femoral block, and I would do a lateral femoral cutaneous block. So, thankfully, the dose of ropivacaine I can use is quite a large dose. So because of that, I use ropivacaine quite a bit. And
okay,
I also like 1% lignocaine and also 1% prilocaine. I do use prilocaine quite a bit in my practice. So these are the 3 local anesthetics I use a lot in my practice.
So you are using all the local anesthetic except bupivacaine, which we are using randomly.
Yes, bupivacaine, obviously, it's a lot time-tested local. There's no question. A lot of my colleagues use it. And if you are doing 1 block, then, because, you're restricted by its mass, isn't it? It's 2 milligrams per kilo. And also the problem with it is the toxicity, the therapeutic window is very small. So for that reason, I tend to use ropivacaine. I haven't got anything against bupivacaine as such.
No, actually, we are not, these ropivacaine or prilocaine, these are not available in our country. That's why we are not used to it. But okay, sir, that's all of the question I have as a text over here. I would like to, yes.
You have missed 1 or 2 questions. There's a question, your experience or comments on awake clavicle surgery.
Awake surgical?
Awake
clavicle surgery.
Ah, that is I have done. I mean, you don't get to see a lot of clavicle operations, but I have used interscalene block and superficial cervical plexus block, the combination, to do clavicle operations. But if you try and find the nerve supply, it's not very easy to find the nerve supply for the clavicle, I think.
So now I would like to actually go on to some open discussion. That's all we have on our question box. Now, Mishu, would you like to please unmute everyone so that everybody can have a clinical discussion? Dr. Mishuk?
Everyone can be unmuted if they want.
Okay. So Dr. Aisha Ali, madam, you raised your hand previously. Would you please ask your question on your own?
Thank you very much for a very detailed and interesting lecture. I just wanted to ask about subclavicular block because of the lower incidence of perhaps complications, especially if you do not have ultrasound scan in certain places and your experience in it.
Did you mean infraclavicular block?
Sorry, infraclavicular block, yes.
So I have done infraclavicular blocks. I'm not a huge fan of them because of where they are located. So, a lot of our patients, at least in the part of the world where I practice in, a lot of them are muscular and they're quite large. So the location of the plexus is quite deep. And also the posterior cord is, so the names lateral cord and medial cord and posterior cord comes from this region. They are located around the axillary artery. And so getting to the posterior cord is quite difficult. And also, you've got the lung going on in the medial aspect of the plexuses. So it's not my favorite block, especially if you haven't got ultrasound. I would not recommend you trying it. Best obviously would be the axillary block. You can use a nerve stimulator or you can use a transarterial technique. Before I arrived to Broomfield Hospital, and this was in 2005, all the blocks in the hospital, for at least the axillary blocks, were performed with a transarterial technique. And we had a reasonably good success rate, like 70% of the blocks were done awake, and there was a big conversion rate. And I came and converted the whole thing to ultrasound guided, and now the conversion rate is almost non-existent. So infraclavicular block, I don't think should be done without ultrasound, in my opinion, because the block is, the location is quite deep. And even with ultrasound, I think you should be really pretty good in practice. You should have done several axillary blocks, maybe superficial blocks, supraclavicular, and then try and attempt infraclavicular because of its deep location, and you've got the blood vessels all very, very tightly packed in a small area.
Thank you very much.
I don't think anyone have any other question. Dr. Shyamol sir, would you like to ask a question? I can see your question over here. Shyamol sir? Shyamol sir, are you there? Okay, I can read his question. So how do you calculate the safe dose in case of a local anesthetic mixture?
Oh, that's that's a classic question. Really, what I try and do is try and keep the dose. There are various tabular forms available. I really don't remember it off the top of my head, but you try and minimize the lowest dose possible of the two local anesthetics. So for instance, if I take 40 mils of local for doing an axillary plexus block, the dose of bupivacaine would be 50 milligrams, and the dose of lignocaine would be 400 milligrams. And that's the combination. I don't think any of us goes beyond that sort of dose range. If I have ropivacaine, then I tend to go a bit higher. So I use about 100 milligrams of ropivacaine instead of 50 milligrams. So I don't think anyone can really tell with confidence that this is what it is. You want to try and keep both the doses of drugs as low as possible, to allow for a good block and also allow for a good length of the block. That's all I can really say, and not just go completely mad with it. I've been using these combinations for the last 15 years, and I really haven't seen any toxicity in our patients. What you do see sometimes is shivering. The patients start to shiver, and that is because of the adrenaline in your mix. So you shouldn't get confused with the shivering becoming as the, being the LA toxicity. It's really the adrenaline that makes the patient shiver, and a bit of midazolam, calms them down. They go to sleep, and the shivering stops.
Can I just ask one more question, please?
Yes,
what's the maximum dose of ropivacaine per kilogram?
It's 3 milligrams per kilo.
Okay, with or without adrenaline, used same?
For longer acting, adrenaline doesn't make a difference to the maximum dose. It's only with lignocaine that it makes a difference.
Okay.
Another question I have in my box, should we keep intralipids available while using bupivacaine in a setup like we have its 3 milligram?
Yeah, I think in any setup, intralipid availability is absolutely important because especially bupivacaine is extremely protein bound, and then the ventricular fibrillation is very, very refractory to the standard treatment. So intralipid has got to be absolutely available in your premises to do these blocks. Yeah.
Okay. We came at the edge of our session. And I think we have answered all of our questions. And now I would like to request our Dr. Lufla sir, so that he can close this session by saying something to us.
Thank you, Nimmi. Thank you, Nair, Ravi. It was a wonderful session, wonderful discussion, and a beautiful presentation. And as Shoykot has also mentioned that it doesn't matter whether you have ultrasound or not. Ultrasound is a very recent thing. Of course, it helps in the safety of the blocks and also accuracy of the blocks. But again, all these blocks were performed under landmark previously. So anything can be done. For safety and accuracy, of course, ultrasound is a very good tool. Thank you, everybody, for staying here till it's late at night, 10:15. And we'll see you again next Tuesday, inshallah. So I'd like to thank everybody, and also again thank Ravi for his wonderful presentations and helping us out here. Thank you. Thank you, everybody.
Thanks very much.
Thank you so much, sir, for being with us. And I would also like to thank you, my IT team, actually, Dr. Kazi Farhana, and of course, Dr. Mishuk, Dr. Salahuddin, who are the hosts and co-hosts. Without them, I'm nothing. And I am just presenting the topics and introduce all things, that's it. And they are the behind who are working hardly and perfectly. And thank you so much. And thank you so much, my senior teachers and my colleagues. Without them, it would not be possible to continue this e-learning program. And of course, we are very much honored, Ravi sir, to have you with us. And we're looking forward to you that you will again join with us, and we can have you physically in our country as well.
Absolutely, absolutely. We are real privilege if I can make it to Bangladesh and come and meet you all. It'll be fantastic.
Yes, sir, that would be our privilege as well.
Yes.
Thank you, sir.
Thank you so much, sir. Okay, good night. Thank you so much.
Good night.
Thank you, Apu.
Allah Hafiz. Thank you, everyone.
Allah Hafiz.
Thank
Good
you
night.
all. Okay, I'll end the meeting.
Bye.
Okay. Bye, sir.
Bye.
দেখা হবে ইনশাআল্লাহ কিছুদিনের
Yes.
মধ্যে। আসসালামু
We'll in touch,
আলাইকুম।
sir. Okay.
Okay, bye, Mishukta.
Okay, bye.